Please, Akim.
Thank you, Lisette, for introducing me and also for your invitation for this important and interesting symposium. After the three exciting presentations, I will try to go through the need for new diagnostic development for schistosomiasis, malaria, and hookworm, and the implementation and the future perspective, particularly coming from endemic area. The perspective will be different maybe from the lab basis, and basically I come from the field where I'm every day. So, sorry, technology. So coming to the introduction, I will highlight the importance of these three poverty-related diseases, mainly malaria, hookworm, and schistosomiasis. As you know already, these three parasitic infections are afflicting African community, mainly poor-related diseases, because this affect people who have limited access to water and also to the clean area and the environment. So these topics are very important because it's affecting poorest population and those who have limited access to the resources and lack education, living in a remote area, and those who have critical health facilities. Therefore, there's a need for effective control program, including testing, diagnosis, and prevention. To determine the prevalence of and the incidence of this infection, we need to be very effective diagnostic tool and accessible to the wide population to be able to know what we want to test, what we want to treat, how to prevent. Without an appropriate diagnostic, there's no possibility to implement a good prevention or any appropriate control for all of these parasitic infections. So coming to malaria, the most deadly parasitic infection ever, at least when this Africa is concerned, the diagnosis of malaria is thought to be very quite empirical in most of the settings because there's a lack of a tool for diagnostic. Every fever are considered as malaria in Africa, while when we make a proper study, this is end out with more or less 20 to 30% of people who are really suffering from malaria, while 100% of people are treated, and this has a consequence for the resistance, which is also very bad for appropriate control. So far, to make it very broad, for what you already know is that the gold standard method for diagnosis of malaria is microscopy for identification of a parasite trophozoite stage in Gisma stain microscopy. This technique is very cheap and easily deployable in the field and can be used to assess the efficacy of treatment, also to follow the incidence of infection. But however, it has some disadvantage because it need to be laboratory. That means you need to be labor intensive, time consumable, at least 60 minutes for from specimen collection to result. This means this need to be performed in the laboratory with people who have been have some experience. Even some experience, we need time to time to refresh this knowledge in the lab, at least when this is concerned for the clinical trial or even in the routine diagnostic lab. People who make a diagnostic of malaria need the refreshment to identify parasite, which is not easy as we can, as most of you may know. So we need well-trained microscopists to be able to perform appropriate diagnostic. Aside this microscopy gold standard technique, we have a rapid diagnostic test which has been developed widely, and this has been seen as a solution for the control of malaria and has been used as the tool for a milestone tool for the WHO for the control of malaria, and because they are very simple to perform and to interpret, faster 15 to 20 minutes from specimen collection to result. You can see that your patient has a circulating antigen or antibodies of malaria parasite, and then you can be treated. Easily deployable in the field as kits can be stored at ambient temperature and doesn't need electricity to be performed, relatively cheap. However, nowadays we have an increasing report of mutation of HIP2, which is there to be the false negative testing. And this is a big issue currently where in some settings, including Gabon, where we have reported some deletion of HIP2, HIP3, a deletion which leads to the false negative sample. So there's a possibility also to have a false, there's a possibility also to have a false positive due to the attribute to even after parasitic was clear, then you don't know when, if, I mean, it's not specific enough to make a decision to treat patient based on the positive rapid diagnostic test. And apart from that, we have more research-oriented techniques, which is molecular diagnostic with a high sensitivity and specificity, and reliable to identify Plasmodium species, especially in case of co-infection, high outputs, and can be used to follow up the treatment efficacy and detect drug resistance parasites are very important, but this cannot be implemented in the field diagnostic or the control of a disease. The disadvantage is that they need for expenses, equipment, and skill of personnel. Not easy to be deployed, of course, because they need electricity, of course, and wherever you need electricity in Africa, this is the challenge. They are time consumable, or we need more than 2 hours from specimen collection to the result. That means this is good for research, but not for what's called the diagnostic on the field. There are flow cytometry, which has the same complications, the same disadvantage as molecular diagnostics, because they need the robust machinery to be able to work. So apart from malaria, which is the more deadly parasitic infection, we have hookworm, which is among those who cause a huge morbidity in Africa. Therefore, the its control also is challenging due to the reinfection, and therefore WHO have implemented the mass drug administration and also WASH a technique, which is also strategy, WASH strategy, water sanitation and the hygiene in endemic area, which are hardly implementable because these people doesn't have access to the water. Therefore, WASH may not be well applied. For this outcome also, for better control, we need a good diagnostic tool. And so far, the best and the gold standard technique is microscopy diagnostic, which allows us to identify egg, larvae, or adult worm, and also to try to identify the species of the hookworm, since we have 2 different kind of species in human, and this is very difficult to be identified using a microscopy. The gold standard is the CATOCAT method with a very good advantage, including sensitivity, which are comparable to direct examination, rapid and cost-effective, feasible in the area with minimal infrastructure, quantitative, which means you can see the burden of the intensity of infection and infected population. The disadvantage of this means that the sensitivity is very low in the light infection. When the infection is very light, that means less density, you may miss to pick up the infection. That's also, there's a requirement for fresh sample and a competent lab technician. Easy to detect hookworm egg within an hour of preparation. This is very important, and that means the technician should be very speed, like from the field sample collection into the lab. This limitation is required to have more sensitive technique, which doesn't need to take in consideration the delay of a sample to get to the lab. So apart from CATOCAT, we have a couple culture, which is which composed of Haramuri techniques, McMaster technique, all of these techniques which promote the culture of egg hash to the larvae. That means we have to identify the larvae of this hookworm in the microscopy, and this will allow us to identify the parasite within 7 days or 10 days. They are cost effective in resource limited setting, semi-quantitative, and can be used in the control program. In general, we combine all of these techniques together. For instance, in our setting at CERMEL, you have to apply for CATOCAT and culture to be able to increase the chance to don't miss a false negative sample. However, this cannot be done in the setting, in the routine. The lab technician will not, they don't have time often to look at, to do different technique before giving the results. The disadvantage to detect larva of hookworm require to be very quickly more than, you have to proceed quickly the staining to avoid that the egg will be lysed. It's not suitable for refrigerated sample. That means you cannot preserve the sample and think of doing the microscopy technique, diagnostic later. Therefore, if you need to perform the diagnostic with a fresh stool sample, they are very time consumable, and then this also need to be improved in terms of implementation. When we look at diagnostic, it's the same advantage, very increasing this sensitivity, specificity. This is available in the setting, but it will be difficult to be used in the routine. And the same disadvantage for previous parasitic diagnostic are available here, apply for this parasitic infection as well. Coming to the schistosomiasis, the most important one, I would say, based on its characteristic, also very spread everywhere in Africa with two main species in the continent. We have Schistosoma mansoni and Schistosoma hematobium. The diagnostic of these parasitic infection is based on the species. If the Schistosoma hematobium species is checked in the urine through the urine filtration, while the Schistosoma mansoni is diagnosed through the diagnosis performed through the catocast. So the advantage of urine filtration is very easy to go, and also but it's very low. The sensitivity is very low because we need to have a huge amount of urine or make several sampling, a multi-sampling of urine to be able to detect the egg when it's a light infection. It's same apply for schistosomiasis as per for a hookworm. It's very, and then for catocats, it's also simple as for hookworm, but low sensitive, and there's a distribution of parasite in the field is even very difficult to assess the accuracy of the intensity. So, sorry. Nevertheless, there's several techniques which are currently developed, and including the one presented by Temitope recently. This is very quite challenging because there's the need for very well sensitive specific tests, but not for these two specificity, but we need also the sample which will be affordable. Among those tests, we have Oliver Gonzalez over precipitation, pericarcerian detachment, and relative fluorescence, ELISA, hemagglutination test, electrophoresis, immune radioimmunoassay. All of these tests are available, but have a lot of limitation. The recent developed technique are CCA, CAA, and the PCR are very interesting, and these are promising, and some of them need to be validated on the field and to be able to be deployed. Some have been already deployed, including CCA, I think, and this technique need also some quite reader, and then there's a hope on this technology of a secretic antigen by WHO to be able to have a proper control of this schistosomiasis. It's very important to have very good diagnostic tool to be able to control for schistosomiasis. In perspective, there is a mobile optic device. These devices have been shown as a proof of concept for diagnosis of helminthic infection. And this case, I put together schistosomiasis and hookworm. And these innovative diagnostic devices are comparatively inexpensive, sensitive, portable sample to perform, with option to store and share healthcare data, making it suitable for Swiss survey of mass drug administration program. It's important to note that nowadays we have a widespread of smartphone, which is accessible for most African countries or developing countries, despite there is a limitation to power. More than somebody said that each African individual have 3 mobile phones, smartphone. That means it's well introduced in the continent and we can take advantage of that. We are looking forward for validation of this technology, which can be something important for the control of helminth infection. For malaria, despite there is a good tool with their limitation, there's a strong interest to a non-invasive saliva-based diagnostic to detect malaria parasite antigen, also including the gametocyte for the control of transmission in the set in the endemic area. So to conclude, I would say that in the future for endemic area, that we need more reliable and simple diagnostic technique and tool for the control of these poverty-related diseases. The smartphone devices are more and more adapted, and then what we have to, the specificity and the sensitivity need to be validated and then to be implemented in the setting area. Powerless devices are also desirable in a limited setting area, in endemic area. Most African countries has a problem with electricity, and therefore this is something we have to take in consideration when developing the new tool for diagnosis of all of these poverty-related diseases. Rapid diagnostic tests are limited in terms of sensitivity and specificity, and hence require confirmation with the gold standard taking some time. So a non-invasive technique using saliva will be preferable in this case, and if they can be used with less power consumable tool. Affordable tests for all socioeconomic status level are required. On this, I will end here and waiting for your question if there is any. Thank you very much for your attention.
Thank you very much, Akim, for a very